Okay, to continue on with the cardiac system, we'll talk about the cardiac conduction system, the electrical portion of the heart. I think this is a good point in which I should mention you have to have both parts play in order for this system to work. If you don't have the muscle part play, obviously blood doesn't get pumped. If you don't have the electrical system play, then the muscle system doesn't know when to pump. So you may hear occasionally about a cardiac condition for some patients in cardiac arrest called PEA, which is pulseless electrical activity. And that pulseless electrical activity means that the electricity is just going to beat the band, but the muscle won't play along. And so it may look like a perfectly normal rhythm on the cardiac monitor, yet the patient, and most times it doesn't, but it can, and the patient has absolutely no heartbeat to go with it. So that's why, again, it's extremely important that we monitor and treat our patients and not our cardiac monitors and our other machines and bells and whistles. Being in tune to what actually is going on with the patient is truly more important than putting on all these machines. So with that being said, let's talk a little bit about the electricity. The typical pacemaker for the heart is the SA node. The SA stands for sinoatrial, and that sinoatrial node will dispatch an electrical stimulus around 60 to 100 times per minute. It will send its stimulus out, and it kind of branches across through the intranodal atrial pathways and then interatrial pathways, where it branches over to the other side, to that left side over there, which would be the left side of the heart as we look at it, the right side, where the little fingerlings are kind of just hanging down across there. Some of that electricity is reconvened in the AV node. It's recollected there at the AV node, and the AV node, it is paused. Just put a very split-second pause in there, and that pause then will allow basically the atria to finish their discharging, get their blood dumped into the ventricles, and then for the ventricles to be ready to go for their cycle. So after that brief pause around at the AV node, the electricity is dispatched down the bundle of His. You also see that referred to as the AV junction there, which is kind of the intersection between the SA, or the top part, atrial part, and the ventricular parts. So if you hear about junctional rhythms, you'll know that they come from that junction. But so it's dispatched down the bundle of His, split down into the left and right bundle branches, and then it's further separated out through some things referred to as fascicles, and then finally down to where we call the Purkinje fibers. And those Purkinje fibers are the ones that actually let the electricity go into the muscle tissue and allow the heart muscle to start to depolarize from basically the bottom up. So now, should there be problems with the SA node and it finishes or it stops working, the AV node and the Purkinje fibers both have backup systems. They both can kick in when necessary. So the AV node might be sitting there waiting, and it's actually a misnomer that we say the AV node. Most people say the AV node. It's actually the AV, or the bundle of His is where this actually comes from. So it's the area right below the AV node. But if the SA node doesn't discharge an impulse within 60 to 100 times a minute, the bundle of His then can pick up the pace, and it can discharge, and it has an intrinsic rate or a normal electric rate of 40 to 60 beats per minute, or 40 to 60 impulses per minute. So sometimes we'll have patients with very slow heart rates that we know comes from the junction. We call them those junctional rhythms, and they're typically in that 40 to 60 beats per minute range. Should the AV node or the junction be knocked out, bundle be knocked out, then the Purkinje fibers kind of have a last-ditch effort where they can discharge an electrical impulse approximately 15 to 40 times per minute. and that's their normal intrinsic rate. So sometimes we have extremely slow heart rates, and something we may call idioventricular, but that typically comes in from those Purkinje fibers. You can't just dice open the heart and see these tracks like it's illustrated here on the screen. It's a microscopic thing, things that are very tiny that are just basically specialized groups of cells. Now, with that being said, they work basically like any other cardiac cells. So if they suffer from a lack of oxygen, they too die. So all those cardiac cells have to conduct electricity, but when we knock out certain areas of cells and those cells die, then that electricity has to be rerouted. It has to go a different direction, and that's what causes us to have some changes on the cardiac monitor. Okay, so I think these next couple slides basically just restate what I had told you. I thought it was more important to look specifically at the slides that showed the picture so we could kind of track where it goes. But remember, it starts at the SA, travels through the atria, reconvenes at the AV, it's paused, spreads down through the bundle, down through the bundle branches into the Purkinje fibers. So our heart is stimulated to contract and to, in a sense, to also discharge electricity, because remember we have to have both parts of this, by the autonomic nervous system. And the autonomic nervous system is our fight or flight. It is counterbalanced by the, back up. The autonomic nervous system is our automatic nervous system, and it mostly, when we think about it, is the fight or flight. But in reality, it also is the rest and digest as well. So and those two parts counterbalance, and that's what counterbalances the autonomic nervous system. So when we're excited and the pager's going off and we're ready to go, it's mostly sympathetic nervous system, where it gives us the epi-norepi rush, and we start to discharge more electricity or more adrenaline into our system, and that causes us to basically go into fight or flight mode. But after we have Thanksgiving dinner and we've stuffed ourselves beyond belief, that actually starts to stimulate the parasympathetic nervous system, which is the rest and digest. It causes us to get sleepy, slows things down, makes the gut kick into a little bit of overdrive there, so the food can be digested and appropriately processed and or stored. So we have some special properties of the myocardium that allow it to contract in a uniform and rhythmic fashion, and this allows that blood to be pumped through the circulatory system. So a cardiac cycle. This is the whole series from start back to the next start. So the heartbeat is a very regular cycle. A series of electrical events produce a mechanical contraction of the heart muscle. And then this electrical activity involves the exchange of the sodium and potassium and the other ions. So we're coming back to that sodium-potassium pump again. And then calcium is required for the contraction of those myocardial cells. So those electrolytes, again, are playing a huge part of this. So when we're concerned with the various electrolytes in a person's body, this is the reason why, because the cells don't contract if they don't have all the required components. So the cardiac action potential, and what that means is the series of the electrolytes changing from one side to the other, and then creating a contraction. But the action potential has two phases. It has a systole phase, which is contraction, and a diastole phase, which is the relaxation phase. So if you've ever wondered where systolic and diastolic came from, here it is. Systole is the heart at work, and diastole, the heart at rest. So, and we know that this happens 60 to 100 times a minute in most cases. Movement of ions and associated differences in electrical charge slip across the cell membrane, and it causes this contraction. So because sodium has X amount of electrons versus potassium has X amount of electrons, the net change is different. If they all had the same number of electrons, neutrons, and protons, we wouldn't see any change when things moved. But when things move, there's a little bit of a difference, just a very slight bit of difference in the amount of electricity that they carry. So, and the heart really functions as two pumps in one. We have the left side versus the right side, and the left side, of course, takes care of the systemic circulation, and the right side takes care of the pulmonary circulation. So it does the same thing twice, kind of. So the cardiac electrophysiology, the heart has a number of properties that it makes it very unique. It has automaticity. I've mentioned this before. It is the one set of muscle cells that really kind of has its own electrical depolarization system. So that SA node is capable of running the electricity for the heart without anybody else telling it to do it. Now, it gets influenced by a few other things, certain nerves and sympathetic nervous system and so on and so forth, but for the most part, it can really do its own thing. It has the properties of excitability, which means these myocardial cells, they can respond to this electrical impulse, they can begin to contract, and most of the other cells, they're really kind of servants and slaves. They also have the ability that they can kick in on their own if they want to, and sometimes they do, and they will create something called VTAC or VFib or AFib, and those sorts of things can override the normal abilities of the heart. It has conductivity, which allows it to move electricity from one cell to another, and very quickly. We also have cardiac output. Cardiac output is really what we're looking for in our patients. We don't have perfect ways to measure all of the factors for cardiac output, so we look at signs and symptoms. We look at the patient's condition to help us assess that. And cardiac output, here's another, I'll make a quick aside here, here's another reason why knowing medical terminology is important, because we know that CO is carbon monoxide, and now we're saying CO is cardiac output. So in this case, being able to put it into a perspective and see which angle they're coming from will help us detect that. They mean cardiac output, or they mean carbon monoxide. So cardiac output is the amount of blood ejected from the heart, and it's determined by really two major factors, which are stroke volume and the heart rate. So stroke volume, the amount of milliliters ejected from the ventricle with each contraction. And a typical, it's also typical stroke volume, or sometimes this also gets referred to sort of kind of correctly by calling it ejection fraction. But the typical stroke volume is somewhere between about 50 and 70 milliliters for most patients. So really we're talking, to put it into probably a little bit more realistic look, around a shot glass to a shot glass and a half worth of blood every time the heart beats is the stroke volume. The heart rate, of course, we know it's typically 60 to 100 times per minute. We simply take the stroke volume. So let's say, for the sake of ease, let's say the stroke volume is 50 milliliters. And we'll say that the heart rate, the patient's tachycardic. The patient has a heart rate of 100. For the sake of ease of math, we take 50 times 100, so 50 of the stroke volume, 100 of the heart rate, and that gives us 5,000, or 5 liters per minute is our cardiac output in this case. It can change. We can have a stronger beating heart. So let's say we have a patient who has a stronger heart doing a better job of pumping blood, and let's say it's pumping out 75 milliliters a minute times 100 is going to give us 7,500, so 7.5 liters. That quickly went up by simply increasing a very small amount to the stroke volume. Now, we can also look at this from a different angle. Let's say that the patient has a slow heart rate, say 50 beats per minute, times 80 for a stroke volume. So we'll pretend that we're a finely tuned athlete. So 50 times 80 gives us 4,000, which is 4 liters per minute. So in reality, that's not too bad when you consider that in the grand scheme of things. So, but let's say you're not a finely tuned athlete and your heart rate is 50. So a heart rate of 50 and you have a stroke volume of 35. Now we're talking 1750, which is really, really low. So by changing one of the two factors, we can see dramatic differences. So sometimes we can come up with the same thing. We could come up with, changing the heart rate and decreasing the amount of stroke volume might come up with the same amount as kind of changing the angle on that. So those subtle changes can be significant, but the nice thing is we have compensation, and when we have compensation, if we have a low stroke volume, maybe because we're low on blood, if our body picks up the heart rate, it brings the cardiac output up to where our norm is. So then it says the average cardiac output is somewhere about 4.9 liters per minute, or 4,900 milliliters. Stroke volume can be adjusted by a couple of factors to help maintain homeostasis. So I talked about how if we change that stroke volume or we change the heart rate, we change the cardiac output. A couple of things: preload, contractility of the heart, and afterload. So a couple of terms here. Preload is the amount of blood that's returning back to the heart. So basically it's what is in the queue to be pushed in for the next contraction. Afterload is the amount of pressure that remains in the arteries that the heart has to beat against. So if we have extremely high blood pressure, our afterload is very high. So typically it also makes it a little higher preload, but we have a very high afterload when we have high blood pressure. So it takes the heart extra work to push the blood out than what it normally would have to. So let's say we have a blood pressure, a systolic blood pressure, or actually blood pressure in general, of 200 over 120. The heart's used to doing 120 over 80, or that's what it's generally designed to do. But if it has to press against that much pressure, it has to work extra hard. So it may cause that body to have to work a little harder. So if we have that high afterload, the heart has to work extra hard. If we have a low preload, then the heart has a difficult time filling. So it can't dispatch a full ventricle worth of blood if the preload is very low. So in many cases, a patient in shock has a low preload. Obviously, the patient with hypertension has a high afterload. The contractility of the heart also adjusts. We have Frank Starling's law. And Frank Starling's law says the more that you stretch the heart, the more it will pump to a point. So when we say that, if we can put extra blood into the heart, we can increase the amount it's going to put out. So that's why sometimes adding a little bit of fluid to a patient, say 400 or 500 milliliters of fluid, can have a drastic result in the way that that their heart pumps and their cardiac output. So we can sometimes see very drastic changes in our patients. So let's talk about vessels a little bit. Arteries, veins, and capillaries. Now we have a couple of bridges between them. We have the artery to capillary bridge, which is the arteriole, and then a capillary to vein bridge, which is a venule. Basically, they're smaller versions of their namesakes. So if we look at the differences here, veins have valves, arteries do not. Arteries are extremely thick-walled and very muscular, where veins are not. Other than that, they're very similar in structure. The capillary themselves are very, very thin. They don't have nearly as many layers as do the arteries and veins, and they become fenestrated, which means they can be mesh-like if they're dilated to a certain extent. We see this happen when we see people with anaphylaxis, where their capillaries become very leaky, and that's because the walls have kind of opened up and allowed extra fluid to kind of rush out, and that's where capillaries become a big problem on occasion. Now, if all of our capillaries in our body opened to their widest at any one time, we would pass out and would have the potential to die, simply for the fact that we have more miles of blood vessels than we have blood to fill them. So if we happen to open up all of our vessels at one time, we will then pool all of our blood out in the extremities and wherever in the capillary beds, and we won't have the amount of pressure to keep it moving through the system. There's one thing I think gets noted in the text. It talks about the alpha-1 receptors. Alpha-1 receptors are the alpha-1 system can be stimulated by epinephrine and norepinephrine, which comes from our sympathetic nervous system. And alpha typically has a high constriction property to it. So when we have a rush of epinephrine, when we have that sympathetic nervous system stimulation, we get this rush of these hormones that causes massive vasoconstriction out in the periphery, so we get kind of pale colored skin, and that's as a result of the alpha-1 being stimulated. And it also causes to have some diaphoresis and sweating as another side effect. So the goal of our cardiovascular system is perfusion, and for perfusion to occur, the blood pressure has to be adequate. So where do we get blood pressure from? Blood pressure typically comes from a couple of things. It comes from the systemic vascular resistance, which you'll note that talked about under cardiac output in 186 on your text. Systemic vascular resistance, which actually affects afterload, is how tight are your blood vessels, particularly your arteries. How tight are your arteries that are controlling the blood flowing through your body? And that blood pressure, systemic vascular resistance times your cardiac output equals your blood pressure. So your heart rate, your cardiac output, and then your systemic vascular resistance are all components of making your blood pressure. And obviously we know the importance of having blood pressure that's significant enough to return blood to the heart for the preload, but low enough yet to allow the heart to work easily against the afterload. So blood pressure itself is the pressure within the arteries on the artery wall during systole, or the heart at work. Diastolic blood pressure is that pressure exerted against the walls of the arteries at rest. So that shouldn't be earth-shattering news there. So the American Heart Association defines the textbook blood pressure as being 120 over 80. And in reality, we like to see it pretty close to that. However, remember, patients do not read the textbook, and so in many cases, we have people who really exceed that. Here's another way to kind of look at it. Your blood pressure should never exceed 90 systolic. Well, I shouldn't say never, almost never. Exceed 90 diastolic. 90 diastolic. So the bottom number should never be over 90. It's just too much afterload for the heart to press against. And the systolic, or the top number, should be, here's a good rule of thumb. For men, up until you reach the age of 50, your blood pressure, your systolic blood pressure should be 100 plus your age. Once you hit age 50, your blood pressure should level out. For ladies, it's 90 plus your age up to the age of 50. So a 50-year-old woman would be 140, would be the maximum systolic we would want to see. More importantly, though, than talking about our systolic and diastolic blood pressures, is the mean arterial pressure. And the mean arterial pressure gets monitored many times in critical care settings, and it's really a more appropriate method of monitoring a patient's vascular output, cardiovascular output. The relationship between this actually ends up being the mean arterial pressure is your cardiac output times your systemic vascular resistance, so basically the same thing regarding your blood pressure. But how do we get to there when it comes to finding this number? Sometimes we get lucky because we'll have a monitor that will do this for us. We may have a cardiac monitor that kind of does the math. But in order, if we really wanted to calculate this and we didn't have that available, we have to have the pulse pressure. And the pulse pressure is very simple to get. It's the difference between your systolic and your diastolic. So if we say, for example, 120 over 80, 120 minus 80, the pulse pressure will then be 40 because that's what's left over. So 40. So using the BP, you would then take their blood pressure, subtract the diastolic from the systolic, and then the mean arterial pressure is the diastolic plus 1/3 of the pulse pressure. So 1/3 of 40 is going to be, what, roughly 13? So we would say 13. So 80 plus 13 would give us a 93. So that's our mean arterial pressure. By taking the diastolic, adding 1/3 of the pulse pressure, gives us the map. So, and that is actually a much better representation of their vascular or cardiovascular output. So if you have the opportunities to start paying attention to mean arterial pressures, I would recommend that you look at it on your non-emergent patients. You have much more time on your hands to deal with that. You can practice doing that, and you can start to really get a better feel for what those mean arterial pressures are. And that's really the number that gets used a lot in the ICUs when they're talking what medication are we going to use to maintain or decrease a blood pressure. So some other influences: the function of the heart, the volume of the blood, the capacity of the vascular system. These are all things that lead to shock. They lead to hypoperfusion. So if the heart is not functioning well because it's had a massive heart attack, then it's not going to pump as hard. If we don't have enough blood running around in our system because we've hemorrhaged, that's a different type of shock. If our capacity of our vascular system, say, is huge, that's a type of shock. So those are actually right there the three major categories of shock: pump failure, pipe failure, or fluid failure. So cardiogenic shock, the heart is not beating at efficiency, so that is pump failure. We have hypovolemic shock, where the patient's bled out, and there's just not enough blood in the system, so that would be a fluid failure. Or we may have a pipe failure, say a patient who's had an anaphylaxis or a severe spinal injury, and all of their blood vessels just decide to do whatever size they want. So they all dilate because it's easy to relax. So they all dilate out. And what happens? Then there's just not enough fluid to fill them. All right, so think about it here. One type of medication that gets used to treat hypertension or high blood pressure is ACE inhibitors. And ACE inhibitors reduce vasoconstriction, thereby lowering blood pressures. So ACE, just to clarify that, ACE for you is angiotensin converting enzyme. It's from a long chain of things in the renin-angiotensin-aldosterone system. We'll talk a little bit more about that when we get to pathophysiology. But this system creates some potent vasoconstrictors. Well, ACE inhibitor would then go in there and block those vasoconstrictors, and then it lets those vessels dilate a little bit more. So some examples of these are the prill drugs, if you notice, and as we start to get towards pharmacology, we start to identify some of these trends we see in the names of certain medications. ACE inhibitors, almost always in their generic name, end in prill. So benazepril, enalapril, and lisinopril, the brand names of those being low-tensin, Vasotec, and Zestril, are all ACE inhibitors. And those ACE inhibitors go in there, the patient will be on this ACE inhibitor, and it doesn't allow their body to constrict quite as much as it would normally. All right, so to move on, talk about control, communication, and integration. Nervous system. So the nervous system obviously is the major communication for our body. We have neurons that take different shapes. They have the same basic features though. Some of them are big, some of them are small. We have dendrites that receive. So you can see the dendrites up towards the upper middle of that picture. They're kind of hair-like. Those dendrites receive input. There's a cell body that processes it and sends it on down the line. And then the axon carries it down the line and takes it down to the end buttons of the axon. And then there's a synapse. The synapse is the space between the nerve cells. So we'll talk about those. So the nervous system allows the integration of sensory input and the coordination of the motor response to it. So we have two major nerve tracts. We have nerves that are sensory nerves. We have nerves that are motor nerves. So we'll have some that bring the info in and some that send the message back out. And so they're not the same nerves. They're different sets of nerves. And not all nerves even communicate directly to the brain. There are certain things called reflexes that only get communicated with the spinal cord, and the brain doesn't even process it. So together with the endocrine system, the nervous system controls a lot of the body, and it communicates in between parts of the body. So between the nervous system sending its various sensory signals and the endocrine system dispatching hormones to change certain things, this is how the body talks organ to organ, system to system. So the neuron is the basic system, basic unit there in that system, and the electricity gets fed down the line there. So look back in your textbook on the picture we were looking at just a moment ago. It's on page 192. You can see on the axon there, it looks like there's little pads around the axon. And that's actually called the myelin sheath. And that myelin sheath is an insulator. It's kind of like when we're doing wiring in our house or in our vehicle, it has that plastic coating around it. A lot of times it's colored, but that coating keeps the message in, doesn't let it just come into contact with anything else and get out. So that's what it keeps it all in. It's an insulator. And that's also the same thing with our nervous system. We have certain diseases in which that myelin sheath then starts to break down, and the messages don't get sent down the line like they're supposed to. But once you get down to the end buttons there, to send the message onto the dendrite of the next neuron, there has to be a chemical in the middle there, and that chemical mediator is called a neurotransmitter, and that's what sends it from one neuron to the next neuron. So think about it in the space, in the gap. Like if you're standing on one riverbank and needed to get to the other riverbank, your neurotransmitter could be a bridge. Okay, so your neurotransmitter would be a bridge there. And otherwise, it kind of, you fall in the river and you're lost. So here's a nice big complicated chart. Look at it on 193 in your textbook. It's easier to read. That kind of breaks our nervous system down. So there are two major nervous systems. There's the central nervous system and the peripheral nervous system. Central nervous system is the brain and the spinal cord. The peripheral nervous system is everything outside the brain and the spinal cord. So the brain and the spinal cord are really responsible for sending messages out to the peripheral nervous system. And the peripheral nervous system is really responsible to bring messages back to the central nervous system. And in many cases, the central nervous system processes what comes in and sends another message back out. Of the peripheral nervous system, it is broken into two major categories. The somatic or voluntary nervous system, which controls skeletal muscle, so the things that we do kind of on our own, and the autonomic nervous system. And that autonomic nervous system is the smooth and the cardiac muscles and the glands that we don't have to think about things. So the heart beats, we don't have to think every 60 to 100 times a minute, heartbeat, heartbeat, heartbeat. It does its own thing. So we have the somatic or voluntary versus the autonomic. The autonomic nervous system is then broken into two additional subdivisions, and the autonomic nervous system breaks into the sympathetic and the parasympathetic. Sympathetic is parasympathetic is rest and digest, and the sympathetic is fight or flight. So when we need to get up and get moving, and or we're out playing a round of, maybe we're playing football or basketball or something, we have a lot of sympathetic stimulation, very little parasympathetic stimulation. When we decide to go to bed at night and sleep, then it's mostly parasympathetic, and they're always in a balance. All right, talked about those. Okay, so our neurons. The neuron structures that we talk about, we have a variety of parts and pieces here. We have the body, which often is referred to as the soma. We have the dendrites, which is obviously the receiving, and we have the axon, which is the sending portion there. We talked about the different types of neurons, where we have sensory versus motor, and we have some interneurons, which are kind of in between. Some of those things in the autonomic nervous system rely on reflexes, so it'll bounce a message to the ganglion there and send it back. And then we have the brain. The brain itself obviously is a pretty amazing piece of equipment, and the brain is divided into several areas that do very specific jobs. So the frontal lobe, that is the one that would be right above your eyebrows, is the frontal lobe on the front of the brain. The majority of the frontal lobe is spent for personality and speech. So personality and speech is really the major components there. People who used to get lobotomies, when they did that, they would actually shove something up their nose and kind of try to scramble their brain a little bit, and it turned them into kind of human zombies. They really had no emotion, and it's because they wiped out a significant portion of their frontal lobe. Towards the middle of the brain, there are parts right along the central fissure that have to do with movement and sensation. Oddly enough, you can track very specific parts of the brain controlling very specific parts of the body, almost as if the body is reflected upside down on the brain there. There's some interesting graphics that you can occasionally find that say, you know, here's where the head is, here's where the hands are, so on and so forth. The parietal lobe of the brain, which is kind of the middle upper back, controls a lot of your language skills. The occipital lobe at the very back, just above the top of your neck, controls your vision. And then the lateral lobes are your senses of smell and hearing, somewhat balance and coordination, but the primary area that controls balance and coordination is the cerebellum underneath all that. So the brain is the central integrating system. Within the cranium, where you'll find the brain, it's cushioned with CSF, or cerebral spinal fluid, which kind of bathes the whole thing, and it is surrounded by meninges. And if you want to take a look at picture on 194 in your textbook, you can see an example of the layers of meninges there. You can see that there is some spaces that there is no tissue, and that's what's filled with cerebrospinal fluid in there. So there's a couple protective layers. One of those, the arachnoid layer, is actually kind of a fluffy layer that allows the fluid to kind of bathe the brain. The cerebrum is the part of the forebrain. It's the center for consciousness and higher thought. Gives us a lot of our humanistic traits. The brain stem is broken into a couple areas, such as the thalamus. The thalamus is a coordination for signals traveling between the cerebrum and the spinal cord. So it's really kind of the dispatcher, or the switchboard hub there. And the hypothalamus really has mostly to do with hormones in the endocrine system. So if you will look at the bottom picture on 195, you will see where these areas are. So you can see the thalamus is kind of tucked inside the cerebrum there, in the middle part of the brain, and the hypothalamus just below it there. Off of there you see the pituitary gland, which is many times referred to as the master gland of the body, because it has a lot of responsibility to control the other glands and send out hormones that tell other parts to send out different hormones. And then we also get to the midbrain, or the brainstem, where we're talking about the vegetative functions. So your heart rate, your respiratory rate, temperature, that's where you will have that all controlled. Well, that midbrain, brainstem area is right up inside the base of the skull there, and when we have somebody who herniates because their brain, their cranium's filling with blood, it pushes on the soft tissue of the brain because the hard tissue won't give. It starts pushing. There's only really one exit here, and that's out the bottom there, out the foramen magnum. And so that gets pushed out. That's the first areas that get pushed out, and that's sometimes why people die from brain injuries. We also have 12 pairs of spinal nerves. 12 pairs of cranial nerves. 12 pairs of cranial nerves that break off the base of the brain stem there. Flip over to 196 in your text, and you will see some representations of those cranial nerves. Cranial nerves have a lot to do with specific functions as far as our senses, mostly to do with our eyes, our taste, and our smell. But we also have a couple of other things. The vagus nerve, which is in there, is a very important nerve. When we talk about heart rate, the vagus nerve comes into play there as well. We also have nerves that run our hearing. Most of the sensory, remember though, is the sense of touch is run via the spinal cord, not via the cranial nerves. So these don't break off the spinal cord; they actually break off the base of the brain. So sensory, cranial nerve number one is the sense of smell. So if we have people who are telling us that they can't smell something, or they're having they're smelling odd odors that nobody else smells, we could have cranial nerve number one being affected. Number two is the optic nerve, which is the sense of vision, being able to interpret what they're seeing. Cranial nerve number 3, 4, and 5 all have to do with ocular movement. So whether it's changing the sides of the pupil or moving the eye side to side, up and down, backwards and forwards, into round, rolling our eyes and whatnot. So 3, 4, and 5, sorry, 3, 4, and 6 are motor nerves for the eye. 5 is the trigeminal nerve, and the trigeminal nerve controls various areas of your face and helps us maintain muscle tension within the face. You hear about people who get trigeminal palsies or Bell's palsy, where they kind of have a droopy face, and also responsible for mastication, which is chewing. Cranial nerve number 7 is the facial nerve, which has to do more with fine facial movements such as expression. Also helps with taste and saliva. Number 8 is the acoustic nerve, and that's the sense of hearing and equilibrium. 9 is the glossopharyngeal, which has a lot to do with the movements of your tongue, and it also has to do with some more taste. 10 is the vagus nerve. I'm going to skip that and come back to that one. 11 is the spinal accessory nerve. That helps with movement of your head, speech, and swallowing. And then 12 is the hypoglossal nerve, which again deals with the movement of your tongue. Going back to the vagus nerve, which is cranial nerve number 10, this has to do with taste, swallowing, and speech, the ability for your skin to have senses, visceral sensibility, so it has to do with your internal organs and being able to detect those. It has some involuntary muscle control. It actually goes and it innervates part of your heart and innervates your gut. So the vagus nerve, very, very big, bad, and important nerve that reaches all throughout the core of your body. We have the reticular activating system. The reticular activating system, or the RAS, network of neurons in your brainstem, thalamus, cerebrum, and it's responsible for our consciousness, our sleep-wake cycles. So when we get up in the morning and have our pot or two of coffee, the caffeine that we're ingesting goes to work on the reticular activating system and tells it, hey, keep this dude awake. The spinal cord, it has a very specific set of tracts and tissues that ascend toward the brain, and tracts and tissues that descend toward the spinal nerves. So some goes up and some goes down. We can see examples of the nerve roots as they come off of the spinal cord. Remember, these typically come out in the spaces between the vertebrae. The layers of the meninges also cover the spinal cord. So we have dura mater, arachnoid layer, and subarachnoid space, as well as the pia mater, which all cover the spinal cord. When we hear about people with spinal meningitis, it's because they have an inflammation or an infection in between some of those layers. And it's putting excessive pressures on the spinal cord. Generally not a good thing. But so you've got those various roots that go out there. You can kind of take a look up there at the top of that picture. If you look at it, you kind of see there's a set of dark-colored wings. Those dark-colored wings in the middle there, that's the gray matter. There's white matter and there's gray matter that compose both the brain and the spinal cord itself. And the various sections of the spinal cord have very specific parts of the body that they deal with. So obviously some of it goes up, some of it goes down. It's not like it's just one big giant wire that goes up and down. There are very specific areas that cover very specific parts of the body. Your spinal cord is a long bundle of nerves. It goes from your brain, your brainstem, down to the level of about your second lumbar vertebrae. So remember, just below the level of where your last rib hooks in on your back there, if you're poking around, that is where your spinal cord ends. There is no more spinal cord that travels down there. Beyond that, we have something called the cauda equina. Cauda equina is kind of a horsetail, and the nerves all are bunched together and travel down outside the spinal canal and take care of the rest of the lower half of the body. When a spinal cord gets injured or severed, all that communication south of that area stops. So if you've just impinged it, you've pinched it, sometimes some of that will come back. If you completely sever it, currently it is incurable. Although they are doing a lot of interesting scientific studies and coming up with some potential new treatments for some of these things. So the peripheral nervous system begins where the spinal nerves and the cranial nerves enter and exit the meningeal coverings of the spinal cord and the brain. So if you kind of look at the picture on 197 again, that is, you see the peripheral nervous system starting really where that bud is on the outside there. So because the grayish color, particularly on the lower couple there, shows the presence of the meninges, and so that yellow nerve that comes out from there, that's the beginning of the peripheral nervous system. We have afferent and efferent nerves. Afferent sensory nerves travel towards the spinal cord, so they're bringing the sensation, they're bringing the messages back. The efferent then is exiting and sending it away to as a motor function to stop, to pull your hand away, to move, to do whatever. And a ganglion is a collection of the nerve cell bodies. So we have ganglions along the edges of the spine, and those ganglion are kind of a meeting area where the messages can all be kind of sorted out. There's the voluntary nervous system that we talked about, things that we have to think about, and we have the autonomic. And I talked about that. It's the sympathetic, fight or flight. The parasympathetic is rest and digest. So another thing about it here, the reticular activating system is an interconnected network of neurons in the brainstem, thalamus, cerebrum that is responsible for sleep and wake cycles and attention. So if we have a trauma to the reticular activating system, what's going to happen? We're going to become unresponsive. So if we become hypoglycemic, maybe we become hypoxic, maybe we're bleeding right there. That's going to all cause unhappy pressures on that reticular activating system, and it's going to cause us to have a decrease in level of consciousness. So a cerebral concussion results from a blow to the head that temporarily disrupts the neural transmissions in the RAS. So, move on to the next system. We talk about, before we go there, I want you to look at 198 in your textbook. This is something called the dermatome map. I don't expect you guys to 100% memorize this, but it's a good idea to look at a couple areas and kind of keep those in mind. The dermatome map, these are the areas of a person's body that are supplied by and sensed by the nerves coming out from various areas. So if we would sever, let's say, our T4, so sever the spinal cord around the T3, T4 area, we would have sensation and potentially motor function down to about our nipple line. So in many cases, if we have an injury that low, if we start to look for other T3s, T4s, we can look and see, well, let's see the arms, that's T1, C8, C7, T2, we're good. So we may only be a paraplegic then. Whereas if we sever something a little higher up, we'll say around the level of the C4, you sever the cord at C4, you might, if you're lucky, be able to shrug your shoulders. So it helps to show you that with the various areas that are affected depending on what spinal nerve gets injured. Now we can look down here and see that there are lumbar vertebrae, or there's L 2, 3, 4, 5, as well as the S's, which are these sacral nerves. Remember, just because we've gone to the cauda equina doesn't mean that there's not a nerve body there or a set of nerves there. It's just not in the cord. So, but kind of interesting to look at. So, okay, so to move on to endocrine. The endocrine system is a various collection of ductless glands. And when we say ductless, this means it doesn't really squirt something out into another area. That's the exocrine. Exocrine would be when we are secreting a fluid or liquid from one spot to another. Endocrine is really more of a chemical mediator that gets sent out. It's almost like instead of squirting it into a supply, it's radiating out. So the endocrine system has a significant number of glands that are all throughout the body, everything from our reproductive organs, areas of our brain, our kidneys. There's parts of our heart that has endocrine abilities. We have some other glands that we don't even commonly think about, and then we have some that we always think about, like our thyroid. So we have these ductless glands. They secrete chemical hormones into the bloodstream. The pituitary gland and the hypothalamus gland are really kind of in charge of all of this. The hypothalamus will secrete a few hormones that will in turn go down to the pituitary gland and tell the pituitary gland to send out more hormones. So, the hypothalamus really kind of passes the buck quite a bit, where the pituitary gland secretes tons and tons and tons of hormones, and some of these hormones are telling other areas to secrete more hormones. So sometimes, the pituitary is just kind of like the little middleman. He doesn't always do a whole heck of a lot, but he coordinates a lot of communication. Some of our other hormones and other areas, we talk about the pancreas. The pancreas has actually endocrine and exocrine roles. It secretes things such as insulin, glucagon, and as endocrine or hormones, and it also secretes certain juices directly into our digestive tract system that help dissolve sugars and are responsible for a lot of carbohydrate maintenance. So it does two things. The adrenal system, which are the small little structures on top of our kidneys, that's where our fight or flight, our sympathetic nervous system, major hormones come from. So when we're talking adrenaline rush, that's where it comes from, the adrenal glands. That causes us to have a lot of stimulation nervous system-wise, but it also has other parts of it that have to do with some of our secondary sexual characteristics like growth of hair and gonads and so on and so forth. So a lot of our steroids come from the adrenal glands. So how is blood glucose related by the pancreatic hormones? Actually, the hormones of the pancreas are always in balance. And there's actually a third one that people don't always think about, but the pancreas secretes glucagon and insulin. Glucagon when we need sugar to be broken down from parts of our body. So glucagon goes and it taps our stored sugar and makes it available, whereas insulin takes any free sugar that's floating around and makes it able to be used by the cells. And then we also have another one that's secreted in there people don't think about. It's somatostatin. And what it does is it actually says release the digestive hormones, and it's going to control the use of insulin and glucagon. It can say, no, we're not going to do any insulin and glucagon, so it can shut them off. Gastrointestinal system. So the gastrointestinal system is the alimentary canal. So this is where enteral drugs go in, And it's everything from your mouth to your rectum and your anus. So it's everything that food travels down and is worked on by the various other structures of the gastrointestinal system. It is responsible for receiving, digesting, absorbing, and excreting. So it takes in the food, starts to break it down physically, puts it into the gut, breaks it down chemically. The intestines then rob the nutrients that it needs and certain amounts of water, and then it creates a solid waste that is eventually gotten rid of. So we start with the mouth, we work our way down through the pharynx, the esophagus, into the stomach, into the small intestine, the large intestine, the rectum, and then out through the anus. So the esophagus is that muscular tube that runs from the oropharynx and connects it to the stomach. Stomach is the muscular container in the upper left quadrant of the abdomen that's responsible for a significant majority of the chemical breakdown of our food. The small intestine is divided into three subsections, the duodenum, the jejunum, and the ileum. Each of those have very specifically defined areas. The roles are not quite as defined. The large intestine does a lot of absorption of water. So think about it this way. You eat your Big Mac, you chew it up, you break it down physically, you move it down your esophagus into the stomach, which the stomach acids and juices then start to break it down chemically, and they create basically a slush. I call it the poopy slush, but in reality it's called chyme, C-H-Y-M-E. Chyme, and this poopy slush then gets moved into the small intestine where it is very, very liquid. Makes it very easy for the blood vessels to swing by and pick up various nutrients there and take it to the liver for it to be processed. By the time now that it's worked its way through nearly 30 feet of small intestine, it's now going to work its way to the large intestine, and it's going to deposit it at the area that they actually coincide is called the ileocecal valve. So obviously the ileum comes into contact with the cecum, which is the large intestine. Hanging off just the bottom of that, interestingly, hanging off the bottom of that area is the vermiform appendix, or what we commonly call the appendix. And the appendix is a vestigial organ that which really doesn't do much now for us. It has some lymphatic tissue, which kind of has maybe a little something to do with the immune system, but not much has been identified that it continues to do. So once that chyme enters that large intestine, then much of the water is pulled out of there. It's a very important area for the body to do kind of a last-ditch pull for water. So if the body's becoming dehydrated, it can rob a lot more water from the large intestine. If you're overhydrated, you may have very loose stools. If you have very loose stools, obviously that may or may not be a great thing. If they're extremely loose, usually that's a lot of trips to the bathroom every day. But so the amount of water that is in your final product is basically controlled at the large intestine. And then it is stored in the rectum. The solid waste is stored in the rectum until a time which the rectum becomes stretched enough that it decides, okay, let's get rid of this. And obviously you get the urge to go to the restroom. Then we have the number of accessory organs that are along the line, whether that's the salivary glands in your mouth where you secrete salivary amylase, which starts to break down starches. We've got the liver, the gallbladder, the pancreas. All of those are responsible for either processing certain chemicals or injecting certain other chemicals, such as bile, into the chyme, which helps it dissolve and break down other substances. So pancreas has a lot to do with starches. Gallbladder has a lot to do with fats. Okay, now, just like we talk about in the lungs having pleura, we have the parietal and the visceral pleura, which cover the outsides of the various organs or the inside of the cavity. So parietal covers the inside of the lung, or inside of the chest cavity, I should say, and the visceral pleura covers the outside of the lung. So when we have the parietal and the visceral pleura up next to each other, it kind of protects them. The same thing happens in the abdomen, and that is referred to as the peritoneum. And it's the same. Visceral peritoneum covers the outside of the organs. Parietal peritoneum covers the inside of the abdominal cavity. Moving on to the urinary system. The urinary system has obviously the kidneys being the major players there. They're the ones that do the filtering and create the urine and control the amount of water that stays in our body. The kidneys, after they create their urine, they discharge their urine down through the ureters. Those two ureters then feed down to the pelvic bowl where the urinary bladder is. And that urinary bladder stores the urine until a time in which a very small sensory area of it called the trigony that is stimulated, that the bladder is stretched, and that allows us to have that sensation of needing to micturate, which means to urinate, and then we can go and get rid of our urine through our urethra. So the kidneys, they maintain the fluid and electrolyte balance, help maintain blood pressure, filter a lot of waste. The more liquid waste. Most of the solid waste, of course, is taken care of by the liver. The urine drains down through the ureters, stored in the bladder, emptied via the urethra. The nephron is the basic unit of the kidney, and if you want to look at pictures on 205, you can kind of see the internal anatomy of the kidney, where it's got these various sections of it, that there are neurons, there's a protective outer covering, there's the renal pelvis in which the liquid drains into, the hilum, we see that term come back again, the hilum is where things enter and exit, and then it leads down into the ureter. So if we go to one of those darker areas of the renal pyramid, we will find the nephron, which is the basic unit. The nephron has the arterial and the venous blood supply that intertwine all around this thing. There's the Bowman's or glomerular capsule, and that glomerular capsule is where a lot of water and chemicals are pulled from the arterial supply. And when that gets pulled from there, it then starts to work its way around through all this tubing, where you see it referred to as distal convoluted tubule, proximal convoluted tubule. We have the descending loop of Henle and the ascending loop of Henle. That's where a lot of these liquids and electrolytes are, and they work their way through the system. And we have this very significant network of blood vessels that surround all those tubules. And those blood vessels can pull and push and pull and push and pull and push, depending on, do we need more water, do we need more sodium, do we need less calcium, do we need more magnesium. It does kind of a tug-of-war thing throughout that maze that it goes through. So finally, after it's gone through this large series of turns and twists, the end product, which has been processed and reprocessed and super processed, ends up in that collecting tubule. The collecting tubule feeds its way down into the renal pelvis, and then the urine is discharged to the bladder. Examples again. The kidneys are also responsible for part of our acid-base system. We talked about that way back in the beginning of this chapter, but the acid base helps control the kidney through a secretion of a compound referred to as bicarbonate. And we brought bicarbonate up before. Chemical symbol for bicarbonate is HCO3, but the HCO3 is secreted by the kidney, and the kidneys will secrete more bicarbonate when it senses that there's a higher acid balance within the body. So in turn, this hopefully decreases our pH. So the all right. So what are our consequences of potential renal failure? Number one, the body becomes very acidic because we don't excrete bicarbonate. Number two, the body doesn't get rid of the urine and the chemicals and the waste products that are brought to the kidney because the kidney can't function to filter it out. So the body easily becomes toxic very quickly. Reproductive systems. The male reproductive system, we can see that the male reproductive organs are actually outside the pelvic cavity. The testes are responsible for creating the sperm and then secreting a number of hormones, namely testosterone. The sperm is then stored in the epididymis until a time in which it needs to be expelled from the body. Then it goes and it feeds up through the vas deferens. The vas deferens wraps up actually over the top of the pelvic bone there, around the top of the urinary bladder, and then comes in back around the backside there and connects in to the urethra through what's referred to as the seminal vesicle, and the seminal vesicle can hold some semen and or some other products of semen, some of the more liquid products of semen, and then the prostate gland. They all funnel through the prostate gland, and finally it gets into the urethra and can be expelled that way. Female reproductive organ, on the other hand, they're all internal. Everything's up inside, and you have the uterus, which is the primary organ where the baby will reside if a woman becomes pregnant. Every 28 days during a woman's fertile years, typically around 28 days, it will shed its lining if it doesn't have an implantation, and that creates a woman's period. On top of the uterus there, you have the fallopian tube, which has some little fingerling-like things that go to the ovary. The ovary and the fallopian tube are not attached. The fallopian tube kind of caresses, I guess, more or less, the ovary and tries to sweep eggs into it as eggs are expelled from the ovary. Typically, a woman will expel 1 to 2 eggs during her ovulation. And then those eggs will, in theory, be swept into the fallopian tube, potentially be fertilized within the fallopian tube, and then find their way down to the uterus for implantation. The bottom of the uterus is the cervix. The cervix is the part of the uterus that becomes thick and swollen and holds the baby in during pregnancy. South of the cervix is the vagina. The vagina is obviously the point of entry for intercourse, and where semen would then be left in order for the woman to become impregnated. You see how the uterus sits on top of the urinary bladder, hence the reason why pregnant women have to pee every 10 seconds. You can see that the woman's urethra is extremely short in comparison to the male urethra. If you look back, the male urethra there is fairly lengthy. The woman's urethra very short. That's the reason why they get a lot of urinary tract infections. And then you have the labia minora and labia majora, which are outer parts to the female reproductive openings, and the clitoris, which is a stimulatory organ. The tissue that's found in the clitoris corresponds to the same tissue that can be found in the head of the penis. So human cells have 23 sets of chromosomes, or a total of 46 chromosomes that are within each of our cells except for our sperm and egg cells. Sperm and egg cells only have 23 chromosomes each, so they have half of what normally a person should have, because when the 23 from the egg merge with the 23 of the sperm, that gives the new organism the full 46 it needs to be a human. The male reproductive organs, we talked about those, as well as the female, and how during the childbearing years, mature ovum is ejected from the ovary into the fallopian tube and is hopefully going to be, well, depending on your perspective, hopefully or unhopefully, going to be fertilized and implanted in the uterine wall. If fertilization doesn't occur, that's when the menstrual cycle begins. The tissue sloughs off every month. The female body produces hormones that makes it a nice, loving, safe, kind environment in the uterus in case an egg would need to grow there, or I should say a fertilized egg would need to grow there. And if it's not necessary, they scrap it and start all over. So obviously the vagina receives the penis during intercourse and allows the discharge during menstruation and serves as the birth canal for childbirth. All right, so obviously the human body is a very complex structure and function. The systems work together, allowing for the body to maintain homeostasis, which is that constant state of zen that we want to be in. We try to learn the normal structure so we can identify abnormal structures as we come across them, and then we understand the roles of the various different systems throughout the body. Now, we are not by any means done with talking about anatomy and physiology. This is just the tip of the iceberg. If you have not read your textbook and done incredible notes and done significant study, you absolutely must do that with this chapter. This chapter has far too much material in it. If I were to go through and give you every single little detail that's found in this chapter, you would be listening to me for hours on end. I think alone with the 3 parts of this lecture for this chapter that I've done, we're well over 3 hours of lecture. So I could spend at least another 3, if not another 5 to 6 hours, talking on the very specifics that you're finding in your chapter. So note those things, and we'll be retouching many of these concepts down the road.